Welcome to this video entitled Upper Respiratory Tract Infections. Let's begin by discussing a few key concepts. 1. Most nonspecific upper respiratory tract infections have a viral, not bacterial, etiology and tend to resolve spontaneously. 2. Each time antibiotics are administered for an upper respiratory tract infection, the recipient is at increased risk of selection and carriage of resistant organisms that can be passed to others. This can lead to future antibiotic failure. 3. Amoxicillin is the drug of choice for acute otitis media. For patients who are suspected of having infection or who are at high risk for infection with drug-resistant Streptococcus pneumoniae, high-dose amoxicillin should be administered. 4. Vaccination against influenza and pneumococcus may decrease the risk of acute otitis media, especially in those with recurrent episodes. 5. Viral and bacterial sinusitis are difficult to differentiate because the clinical presentations are similar. Viral infections, however, tend to resolve by 7 to 10 days. Persistence of symptoms beyond this time likely indicates a bacterial infection. 6. Amoxicillin is first-line treatment for acute bacterial sinusitis. Since there is no difference in clinical outcome among antibiotics, the advantages of amoxicillin include proven efficacy and safety, a relatively narrow spectrum that minimizes emergence of resistance, good tolerability, and low cost. 7. Group A, beta hemolytic streptococcus, that is Streptococcus pyogenes, is the most common bacterial cause of pharyngitis, and despite representing a small percentage of causes of pharyngitis, it is the only commonly occurring form of acute pharyngitis for which antimicrobial therapy is indicated. 8. Antimicrobial treatment of pharyngitis should be limited to those who have clinical and epidemiologic features of Group A, streptococcal pharyngitis with a positive laboratory test. Penicillin is first-line treatment. Amoxicillin can be used for children because of its better taste. 9. The evidence that treatment of Group A, streptococcal pharyngitis prevents rheumatic fever comes solely from studies using depot intramuscular penicillin. Penicillin administered by other routes has been assumed to be equally efficacious. The ability of other antibiotics to eradicate Group A streptococcus has led to extrapolation that these agents also will prevent rheumatic fever. Upper respiratory tract infections include otitis media, sinusitis, pharyngitis, laryngitis, also known as croup, rhinitis, and epiglottitis. These infections are responsible for the majority of antibiotics prescribed in ambulatory practice in the United States. In 1998, the estimated cost of otitis media was $3 to $4 billion in the United States and $600 million in Canada. Most nonspecific upper respiratory tract infections have a viral, not bacterial, etiology and tend to resolve spontaneously. Strategies for limiting unnecessary antibiotic use have been developed in an effort to address the problem of increased bacterial resistance that is associated with antibiotic use. This is particularly important for Streptococcus pneumoniae, the leading bacterial cause of meningitis, pneumonia, otitis media, and sinusitis. In Canada, an average of 15 deaths per year due to Streptococcus pneumoniae are reported in children younger than 5 years of age. This chapter will focus primarily on otitis media, pharyngitis, and sinusitis because these infectious entities are frequently bacterial in origin, and appropriate antibiotic treatment can minimize morbidity and potentially prevent complications. Next we will discuss otitis media. Otitis media is inflammation of the middle ear. The diagnosis of acute otitis media includes signs and symptoms of infection of the middle ear, such as atalgia, fever, and irritability, as well as the presence of fluid in the middle ear. In otitis media with effusion, middle ear fluid is present, but signs and symptoms of infection are absent. Otitis media is most common in infants and children, 75% of whom have had at least one episode by the age of 1 year. About 20% of otitis cases occur in adults, particularly in those with a history of these infections as a child. Table 107.1 lists the risk factors for otitis media. Risk factors for otitis media owing to resistant pathogens include 1. Daycare attendance, 2. Prior antibiotic exposure, and 3. Age younger than 2 years. Pause the video and carefully scrutinize Table 107.1 summarizing the risk factors for otitis media before advancing to the next slide. Next we will discuss the pathophysiology of otitis media. Acute otitis media usually follows a viral upper respiratory tract infection that causes eustachian tube dysfunction and mucosal swelling in the middle ear. Bacteria and viruses that colonize the nasopharynx thus enter the middle ear and are not cleared properly by the mucociliary system. In the presence of effusion, the bacteria proliferate and cause infection. Children tend to be more susceptible to otitis media than adults because the anatomy of the eustachian tube is shorter and more horizontal, facilitating bacterial entry into the middle ear. Next we will discuss the microbiology of otitis media. Streptococcus pneumoniae is the most common bacterial cause of acute otitis media, with an incidence of 20% to 35%. Non-typable Haemophilus influenza and Moraxella catarrhalis are each responsible for 20% to 30% and 20% of cases, respectively. Bacterial organisms that have been associated less frequently with otitis media include Staphylococcus aureus, Streptococcus pyogenes, and gram-negative bacilli such as Pseudomonas aeruginosa. In 20% to 30% of cases, no bacterial pathogen is found, and in up to 44%, a viral etiology is found with or without concomitant bacteria. We will now briefly discuss bacterial resistance. Bacterial resistance to antimicrobial therapy for acute otitis media is of growing concern, particularly in view of the increasing levels of drug-resistant Streptococcus pneumoniae. Data from the United States 1999 to 2000 indicate that 8.3% to 34.2% of all Streptococcus pneumoniae isolates are penicillin non-susceptible, minimum inhibitory concentration (MIC) equal to 0.12 to 1 microgram per milliliter, that 12.2% to 21.5% are highly penicillin resistant (MIC equal to or greater than 2 microgram per milliliter, and that these rates are highly variable based on regional differences. Canadian data from isolates collected between 1997 and 2002 indicate that 20.2% of Streptococcus pneumoniae isolates are penicillin non-susceptible. High-level penicillin resistance increased from 2.4% to 13.8% from 1999 to 2002, and multidrug resistance was reported at 8.8% in 2002. Multi-drug resistance in the United States is reported as 12.2% to 22.4% of Streptococcus pneumoniae isolates. Multidrug resistance is defined as concomitant resistance to at least 3 different antibiotic classes. Antibiotic resistance rates with other beta-lactams, penicillins other than penicillin, as well as cephalosporins, macrolides, azithromycin and clarithromycin, clindamycin, trimethoprim sulfamethoxazole, tetracyclines, and fluoroquinolones also must be considered. In otitis media, non-beta-lactam antibiotic treatment is mostly considered when penicillin-allergic patients are treated or when treatment failure occurs. Streptococcus pneumoniae resistance to amoxicillin with or without clavulanate is reported to range from 1% to 14%. The second-generation cephalosporins that were most active were cefuroxime and kevaprozole, followed by cefiexime and cefaclor, with resistance rates of 6% to 12% in Canada and about 25% to 50% in the United States. The approximate rates of resistance for individual classes are clarithromycin, that is 8% to 26%, trimethoprim sulfamethoxazole, that is 16% to 30%, doxycycline, that is 4%, and levofloxacin, that is 1%. Beta-lactamase-producing Haemophilus influenza and Moraxella catarrhalis are found in 23% to 35% and up to 100% of infected patients, respectively. It is important to note that susceptibilities vary by geographic region, particularly for Haemophilus influenza. While these organisms tend to cause infection that is more likely to resolve spontaneously as compared with Streptococcus pneumoniae, they are still pathogens that must be accounted for, particularly in treatment failures. 2. Bacterial resistance increases with antibiotic usage such that it is difficult to achieve an appropriate balance between antibiotic prescribing and minimizing resistance. Each time antibiotics are administered, the recipient is at increased risk of selection and carriage of resistant organisms that can be passed to others. This can lead to future antibiotic failure. Without antibiotic therapy, however, acute otitis media secondary to Streptococcus pneumoniae is less likely to resolve spontaneously than that from other causes. Streptococcus pneumoniae is increasingly resistant to penicillin, and penicillin-resistant Streptococcus pneumoniae is more likely to be resistant to multiple antibiotics. Pause the video and carefully scrutinize Table 107-2 summarizing clinical presentation of acute otitis media before advancing to the next slide. We will now look at the clinical presentation and diagnosis of otitis media. Acute otitis media presents as an acute onset of signs and symptoms of middle ear infection such as atalgia, irritability, and tugging on the ear, following cold symptoms of runny nose, nasal congestion, or cough, as shown in Table 107-2. Resolution of the symptoms of acute otitis media occurs over 1 week. Pain and fever tend to resolve after 2 to 3 days, with most children becoming asymptomatic at 7 days. Over a period of 1 week, changes in the eardrum normalize, and the pus becomes serous fluid. Air fluid levels are apparent behind the eardrum, at which the stage is now referred to as otitis media with effusion. This does not represent ongoing infection, nor are additional antibiotics required. Otitis media with effusion also can occur de novo and is thought to be a result of respiratory viruses. Otitis media with effusion usually occurs in spring or autumn, not winter, and may be a result of allergens or viruses common at these times. It also differs from acute otitis media in that pain is not present, nor a bulging eardrum. Effusions resolve slowly. At 3 months, 90% have disappeared. Younger children or those with a history of recurrent infections have a further delay in resolution. Because of symptoms of viral upper respiratory tract infection, the common cold, antibiotics frequently are prescribed for otitis media with effusion but are not needed if duration is less than 3 months. Limiting antibiotic use to documented acute otitis media would save up to $8 million annually in the United States. Unfortunately, the longer the time spent with otitis media with effusion, the higher is the likelihood of poor linguistic performance. Complications of otitis media are infrequent but include mastoiditis, bacteremia, meningitis, and auditory sequelae. We will now discuss the treatment of acute otitis media. Regarding the desired outcome, the goals of treatment of acute otitis media are the reduction in signs and symptoms, eradication of the infection, and prevention of complications. Avoidance of unnecessary antibiotic prescribing is another goal in view of the increasing problem of Streptococcus pneumoniae resistance. Next we will discuss general approach to treatment. The management of acute otitis media is not without controversy. For example, a systematic review of studies demonstrated that antimicrobial therapy provides resolution of symptoms in about 95% of patients, whereas about 80% of placebo-treated patients also have a resolution of symptoms. Although only a small benefit has been found, antimicrobial treatment is still considered an appropriate management strategy. However, the choices of which patient should receive antimicrobials, which antimicrobial regimen, and at what point antibiotics should be given after diagnosis require further evaluation. Generally, otitis media is treated empirically without laboratory tests. Next we will look at the non-pharmacologic therapy of otitis media. Acetaminophen or a non-steroidal anti-inflammatory agent such as ibuprofen can be used to relieve pain and malaise in acute otitis media. Decongestants, antihistamines, topical corticosteroids, and expectorants have not been proved effective for acute otitis media. Side effects associated with these treatments also may be unpleasant. Surgical insertion of tympanostomy tubes (T-tubes) is an effective method for the prevention of recurrent otitis media. These small tubes are placed through the inferior portion of the tympanic membrane under general anesthesia and aerate the middle ear. Children with recurrent otitis who have more than 3 episodes in 6 months or 4 or more episodes, one of which is recent, in a year should be considered for T-tube placement. If these children have moderate to severe nasal obstruction in addition to recurrent otitis, adenoidectomy may be of benefit. Tonsillectomy, however, is not indicated for the treatment of otitis media. Although T-tube insertion is effective for many, some children may require subsequent surgeries. Repeat T-tube placement with adenoidectomy, regardless of adenoid size, should be considered if the child continues to have episodes of acute otitis media after extrusion of the original T-tubes. Next we will discuss the pharmacologic therapy of otitis media. We will begin with antimicrobial therapy. Acute otitis media must be distinguished from otitis media with effusion. Antimicrobials are indicated only in the former unless the effusion persists beyond 3 months in otitis media with effusion. Middle ear effusion in acute otitis media tends to continue after antimicrobial therapy is completed but does not require retreatment. Studies have not demonstrated any one antimicrobial agent to be superior in the treatment of acute uncomplicated otitis media. Amoxicillin is considered the drug of choice regardless of the prevalence of drug-resistant Streptococcus pneumoniae. Amoxicillin has the best pharmacodynamic profile time above the minimum inhibitory concentration (MIC90) in the middle ear fluid for more than 40% of the dosing interval against drug-resistant Streptococcus pneumoniae of all available oral agents. It has a long record of safety, it possesses a narrow spectrum, and it is inexpensive. Its excellent efficacy against Streptococcus pneumoniae outweighs the issue of beta-lactamers producing Haemophilus influenza and Moraxella catarrhalis, against which amoxicillin may not be effective. This is so because Haemophilus influenza and Moraxella catarrhalis are both more likely to lead to a spontaneous resolution of the infection compared with Streptococcus pneumoniae. Amoxicillin is the drug of choice for acute otitis media. High-dose amoxicillin, dosed at 80 to 90 mg per kilogram per day, is recommended if drug-resistant Streptococcus pneumoniae is suspected or a patient is at high risk for a resistant infection. Treatment recommendations for acute otitis media are found in Table 107.3. Patients who have received a course of antibiotics within the last 3 months are considered high risk. Higher middle ear fluid concentrations of amoxicillin as a result of higher dosing should overcome drug-resistant Streptococcus pneumoniae even with its increased MIC. Some clinicians have expressed concerns, however, about the increased risk of adverse effects and patient noncompliance associated with high-dose amoxicillin. If treatment failure occurs with amoxicillin, an agent should be chosen with activity against beta-lactamase producing Haemophilus influenza and Moraxella catarrhalis, as well as drug-resistant Streptococcus pneumoniae. Examples include amoxicillin clavulanate, cefuroxime, and intramuscular ceftriaxone. Second-generation cephalosporins, while beta-lactamase stable, are expensive, have an increased incidence of side effects, and may increase selective pressure for resistant bacteria. They also are less effective against drug-resistant Streptococcus pneumoniae. Consideration also must be given to the fact that most cephalosporins do not achieve adequate middle ear fluid concentrations against drug-resistant Streptococcus pneumoniae for the desired duration over the dosing interval. Oral cephalosporins that may be tried include cefuroxime, as advocated by the Centers for Disease Control and Prevention (CDC) guidelines, as well as keviprozole or CEPH-podoxime. Intramuscular ceftriaxone is the only agent other than amoxicillin that achieves middle ear fluid concentrations above the MIC for more than 40% of the dosing interval. While single doses have been used, daily doses for 3 days are recommended to optimize clinical outcomes. Ceftriaxone should be reserved for severe and unresponsive infections or for patients in whom oral medication is inappropriate because of vomiting, diarrhea, or possible non-adherence. Ceftriaxone is an expensive agent, and the intramuscular injections generally are not appealing to young patients. Tympanocentesis also can be considered for treatment failure. It has a therapeutic effect of relieving pain and pressure and can be used to collect fluid to identify the causative agent. This procedure, however, is not frequently performed in practice. Pause the video and carefully scrutinize Table 107.3 summarizing acute otitis media treatment recommendations before advancing to the next slide. We will now discuss a clinical controversy. It is not clear when antibiotics should be prescribed for acute otitis media at the onset of signs and symptoms or after 48 to 72 hours to allow assessment for a spontaneous resolution. In general, the North American approach is to institute empirical treatment immediately. In some European countries such as the Netherlands, the practice is not to initiate treatment initially, but rather to treat a child 6 months to 2 years of age only if he or she does not improve by 24 hours or an older child by 72 hours. Patients with penicillin allergy can be treated with several alternative antibiotics. Some clinicians feel that the incidence of cross-reaction is sufficiently low that use of a cephalosporin is warranted in patients who have not experienced immediate penicillin hypersensitivity reactions. Others prefer to use a macrolide such as azithromycin or clarithromycin, erythromycin sulfasoxazole, trimethoprim sulfamethoxazole, or if Streptococcus pneumoniae is documented, clindamycin as alternative agents. However, the incidence of resistance is much higher with these agents, and of these agents, only clindamycin is recommended by the CDC guidelines. We will now discuss delayed antimicrobial therapy. It is difficult to identify who will benefit from antimicrobial therapy. With or without treatment, about 60% of children who have acute otitis media are symptom-free within 24 hours. In almost 40% of the remaining children, antibiotic use reduces the duration of symptoms by about 1 day. A trial of 315 children, 6 months to 10 years of age, compared immediate antibiotic treatment with a 72-hour delay in treatment that was to be given only if the child had not improved. Symptoms continued for one extra day in 10% to 20% of the delayed therapy group, but 10% fewer also experienced diarrhea. At 3 days, there was no difference in symptoms. In the delayed therapy group, only 24% of children eventually received antibiotics, and 77% of parents reported being satisfied with this approach. Delayed treatment decreases antibiotic use by 31% and associated side effects, and minimizes bacterial resistance to rates as low as 30% to 50% of that in countries that do not delay antimicrobial therapy. Some clinicians feel that delayed treatment is not advisable in children younger than 2 years of age, those with recent antimicrobial exposure, or when underlying conditions exist because these patients are at increased risk of susceptibility to invasive disease and resistant bacterial infections. If delayed therapy is tried, use of appropriate pain medication, such as oral ibuprofen or acetaminophen, should be advised. If a child 6 months to 2 years of age does not improve by 24 hours or an older child by 72 hours, antibiotic treatment should be initiated. In addition to the desire for immediate symptom improvement, prevention of mastoiditis and meningitis has been suggested as a reason to prescribe immediate antibiotic treatment for acute otitis media. The rates of mastoiditis in the Netherlands, Norway, and Denmark, all countries in which delayed therapy has been adopted, and those in Canada, the United States, Australia, and the United Kingdom were compared. The delay of antibiotic use resulted in an increase from about 2 to 4 cases of mastoiditis per 100,000 children per year, accompanied by about 1,600 fewer children per 100,000 experiencing antibiotic side effects. Of note, in the Netherlands, only 1.1% of infections caused by Streptococcus pneumoniae are penicillin resistant. We will now discuss short courses of therapy. A meta-analysis of 32 trials reported no difference in cure rates after short, that is less than 7 days, and usual durations, that is equal to or longer than 7 days, of antibiotic therapy in children. The authors suggest that 5 days of therapy is effective in acute uncomplicated otitis media. The advantages of short-term therapy are an increased likelihood the patient will adhere to the full course of treatment and decreased bacterial selective pressure for both the individual and the community. The disadvantages are that the data are not well established for complicated or recurrent acute otitis media, and there are inadequate data to support short treatment courses in children younger than 2 years of age. We will now discuss a clinical controversy. The optimal duration of antimicrobial therapy for otitis media has not been established. Some studies have demonstrated efficacy with 3 to 5 days of therapy in acute uncomplicated otitis media. However, high-risk populations, e.g., children younger than 3 years of age and those with resistant or recurrent infections, were not studied. Next we will discuss the evaluation of therapeutic outcomes. Treatment failure is a lack of clinical improvement after 3 days in the signs and symptoms of infection, including pain, fever, and redness, bulging of the tympanic membrane. Early re-evaluation of the eardrum when signs and symptoms are improving can be misleading because effusions persist. A concern that requires evaluation after otitis infections is hearing loss resulting from persistent middle ear effusions. Examination of an asymptomatic child may be delayed until 3 months after the infection began, at which time the continued presence of fluid should prompt a hearing evaluation. And now we will discuss antibiotic prophylaxis of recurrent infections. Recurrent otitis media is defined as at least 3 episodes in 6 months or at least 4 episodes in 12 months. Recurrent infections are of concern because patients younger than 3 years of age are at high risk for hearing loss and language and learning disabilities. Data from studies generally do not favor prophylaxis. A meta-analysis demonstrated that prophylaxis against these infections leads to a reduction of 0.11 episodes per month. This translates into 1 infection prevented each time one child is treated for 9 months. Prophylaxis is even less effective in those with effusion. Amoxicillin 20 mg per kilogram per day and sulfasoxazole 75 mg per kilogram per day have been evaluated. Success with sulfasoxazole generally is thought to be better because it results in less carriage of resistant organisms. However, side effects are much worse, i.e., rash, mouth sores, and potential for blood dyscrasias. Of further concern is antibiotic resistance as a result of continued use of these antibiotics. For this reason, treatment can be delayed until the onset of symptoms of an upper respiratory tract infection, viral symptoms. Another approach is to limit antibiotic prophylaxis duration to 6 months and during the winter months. T-tube placement, adenoidectomy, and tonsillectomy may be of value in children with recurrent treatment failure. We will now discuss vaccination. Vaccination against influenza and pneumococcus may decrease the risk of acute otitis media, especially in those with recurrent episodes. Immunization with the influenza vaccine has been associated with up to a 36% reduction in the incidence of acute otitis media infection. Others have described a benefit during the influenza season. The influenza vaccine can be administered to any healthy person without contraindications, especially individuals with chronic disease who are at least 6 months of age. Some clinicians feel that the data do not justify universal influenza vaccination but that it is warranted for high-risk patients, including those younger than 2 years of age. A conjugate pneumococcal vaccine that is indicated in infants and children has become available and provides a 6% reduction in the frequency of acute otitis media and a 20% reduction in the need for placement of a T-tube. Also, vaccine use has demonstrated an 8% decrease in office visits, as well as a 10% to 26% decrease in otitis media episodes in children who experienced 3 to 10 infections per year. Pneumococcal conjugate vaccine is recommended for all children aged 2 to 23 months. It is also recommended for those 24 to 59 months of age who are at high risk of invasive disease. Previously unvaccinated children older than age 1 who have had recurrent otitis media infections do not benefit from later vaccination. Next we will discuss sinusitis. Sinusitis is an inflammation and/or infection of the paranasal sinus mucosa. The term rhinosinusitis is used by some specialists because sinusitis typically also involves the nasal mucosa. The majority of these infections are viral in origin, nevertheless, antimicrobials are prescribed frequently. It is thus important to differentiate between viral and bacterial sinusitis to aid in optimizing treatment decisions. Viral sinusitis and bacterial sinusitis are difficult to differentiate because the clinical presentations are similar. Viral infections, however, tend to resolve by 7 to 10 days. Persistence of symptoms beyond this time likely indicates a bacterial infection. Bacterial sinusitis can be categorized into acute and chronic disease. Acute disease lasts less than 30 days with complete resolution of symptoms. Chronic sinusitis is defined as episodes of inflammation lasting more than 3 months with persistence of respiratory symptoms. Sinusitis is diagnosed more frequently in children than in adults. Typical clinical presentation and diagnosis of bacterial sinusitis are illustrated in Table 107-4. Between 5% and 13% of viral upper respiratory tract infections in children are complicated by bacterial sinusitis, whereas only 0.5% to 2% of viral upper respiratory tract infections in adults are complicated by sinusitis. Factors associated with the development of bacterial sinusitis include viral respiratory tract infections and, less commonly, allergic inflammation. Other factors that can be associated with sinus disease include systemic diseases, trauma, environmental exposures, and anatomic abnormalities. Pause the video and carefully scrutinize Table 107 for summarizing clinical presentation and diagnosis of bacterial sinusitis before advancing to the next slide. Next we will discuss the pathophysiology of sinusitis. Similar to acute otitis media, acute sinusitis usually is preceded by a viral respiratory tract infection that causes mucosal inflammation. This can lead to obstruction of the sinus ostia, the pathways that drain the sinuses. Mucosal secretions become trapped, local defenses are impaired, and bacteria from adjacent surfaces begin to proliferate. The pathogenesis of chronic sinusitis has not been well studied. Whether it is caused by more persistent pathogens or there is a subtle defect in the host's immune function, some patients develop chronic symptoms after their acute infection. Next we will discuss the microbiology of sinusitis. Viruses are responsible for most cases of acute sinusitis, however, when symptoms are persistent, equal to or longer than 7 days, or severe, bacteria may be a primary cause or the cause of secondary infection. Acute sinusitis that is bacterial in origin is caused most often by the same bacteria implicated in acute otitis media, Streptococcus pneumoniae and Haemophilus influenza. These organisms are responsible for about 70% of bacterial causes of acute sinusitis in both adults and children. Moraxella catarrhalis is also frequently implicated in children, that is 25%. Streptococcus pyogenes, Staphylococcus aureus, fungi, and anaerobes have been associated less frequently with acute sinusitis. Chronic sinusitis can be polymicrobial with an increased prevalence of anaerobes, as well as less common pathogens, including gram-negative bacilli and fungi. Issues of bacterial resistance are similar to those found with otitis media and are further addressed in that section of this chapter. Next we will discuss the treatment of sinusitis. Let's begin with the desired outcome. The goals of treatment of acute sinusitis are the reduction in signs and symptoms, achieving and maintaining patency of the ostia, limiting antimicrobial treatment to those who may benefit, eradication of bacterial infection with appropriate antimicrobial therapy, minimizing the duration of illness, prevention of complications, and prevention of progression from acute disease to chronic disease. Next we will discuss a general approach to treatment. Approximately 40% to 60% of patients with acute sinusitis will recover spontaneously. These are likely patients with viral sinusitis. When the decision to treat with antimicrobials thus is made, the choice must be effective and safe, and cost must be considered. And now we will discuss a clinical controversy. Is antimicrobial treatment warranted in bacterial sinusitis? Since most studies have not used sinus aspiration to diagnose bacterial sinusitis, many patients with viral infections likely have diluted the results of studies of antimicrobial therapy. It is recommended that patients with mild acute sinusitis can be given decongestants and reassurance, whereas those with moderate to severe disease for 7 days or more and those with severe disease should be given antimicrobial therapy. Next we will discuss non-pharmacologic therapy. Data regarding supportive therapy are limited, but such therapy may be useful. Nasal decongestant sprays such as phenylephrine and oxymetazoline that reduce inflammation by vasoconstriction are used often in sinusitis. Use should be limited to the recommended duration of the product to prevent rebound congestion. Oral decongestants also may aid in nasal sinus patency. To reduce mucociliary function, irrigation of the nasal cavity with saline and steam inhalation may be used to increase mucosal moisture, and mucolytics, e.g., guaifenesin, may be used to decrease the viscosity of nasal secretions. Antihistamines should not be used for acute bacterial sinusitis in view of their anticholinergic effects that can dry mucosa and disturb clearance of mucosal secretions. Second-generation antihistamines may play a role in chronic sinusitis where allergy is a component. Glucocorticoids intranasally decrease tissue inflammation and edema, however, delayed onset limits the usefulness in acute sinusitis. Next we will discuss pharmacologic therapy of sinusitis. Let's begin with antimicrobial therapy. Two meta-analyses have demonstrated that antimicrobial therapy is superior to placebo in reducing or eliminating symptoms, although the benefit is small. Two randomized, controlled, double-blind studies reported conflicting results as to the value of antimicrobial therapy. Neither used sinus aspiration for diagnosis. The study that showed no benefit with antibiotic treatment had two major flaws. Radiography was used for diagnosis of sinusitis, and duration of illness was not specified. Viral infection thus was likely present in a number of patients, complicating evaluation of antimicrobial usefulness. The second study demonstrated the effectiveness of penicillin and amoxicillin in patients with at least 7 days of illness and findings of sinusitis on computed tomography. Because of more rigorous inclusion criteria and better diagnostic tools, patients with bacterial sinusitis were included, and those with viral sinusitis were more likely excluded. Amoxicillin is first-line treatment for acute bacterial sinusitis. Since there is no difference in clinical outcome among antibiotics, the advantages of amoxicillin include proven efficacy and safety, a relatively narrow antibacterial spectrum that minimizes emergence of resistance, good tolerability, and low cost. Most consensus reports and reviews consider amoxicillin as first-line treatment for acute bacterial sinusitis as shown in Table 107.5. It is cost-effective in acute uncomplicated disease, and initial use of newer broad-spectrum agents is not justified. If a patient is penicillin allergic, azithromycin or clarithromycin may be used. In adults, a quinolone such as levofloxacin is an alternative in the penicillin-allergic patient. If the penicillin allergy is not a true IgE-mediated reaction, e.g., hives or anaphylaxis, a second-generation cephalosporin may be used, e.g., cefprozil, cefuroxime, or cefpodoxime. If drug-resistant Streptococcus pneumoniae is highly suspected, day care attendants, recent antibiotic use, age younger than 2 years, high-dose amoxicillin should be given. Some recommend clindamycin, but it is important to note that this drug is not active against Haemophilus influenza and Moraxella catarrhalis. In the case of treatment failure with amoxicillin, i.e., no improvement in symptoms 72 hours after starting therapy, or in patients who have received antimicrobial therapy in the prior 4 to 6 weeks, improved coverage of Haemophilus influenza and Moraxella catarrhalis with either high-dose amoxicillin plus clavulanate or a beta-lactamase stable cephalosporin that covers Streptococcus pneumoniae, e.g., cefprozil, cefuroxime, or cefpodoxime, is suggested. Other alternatives include IS-2, IS-3, cefdinir, azithromycin, clarithromycin, and trimethoprim sulfamethoxazole. Clinical cure rates are similar among antimicrobial agents, although local area resistance rates also must be considered. Increasing resistance of Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis to trimethoprim sulfamethoxazole and resistance of Streptococcus pneumoniae to macrolides must be taken into consideration. See Table 107-6 for dosing guidelines. Duration of therapy for treatment of sinusitis is not well established. Most trials have used 10 to 14-day antimicrobial courses, although some trials also have investigated courses as short as 3 days. In one placebo-controlled comparison of 3 versus 10-day treatment with trimethoprim sulfamethoxazole and decongestant, a similar number in each group were cured or improved at 14 days. Since the publication of this study, however, rates of resistant S. pneumoniae have increased dramatically, and trimethoprim sulfamethoxazole is not an effective agent against resistant Streptococcus pneumoniae. Furthermore, extrapolation of these results to other antimicrobials is not appropriate. Therefore, the current recommendations are 10 to 14 days of antimicrobial therapy or at least 7 days after signs and symptoms are under control. Pause the video and carefully scrutinize Table 107-5 summarizing approach to treatment of acute bacterial sinusitis before advancing to the next slide. Pause the video and carefully scrutinize Table 107-6 summarizing dosing guidelines for acute bacterial sinusitis before advancing to the next slide. We will now discuss the evaluation of therapeutic outcomes. Antimicrobial therapy reduces the median duration of illness from 17 to 9 to 11 days. A patient with persistence or worsening of symptoms 72 hours after initiating antimicrobial therapy may be considered a treatment failure. Referral to a specialist should be considered in patients who have not responded to first or second-line therapy, those with recurrent and chronic disease, and patients at risk for complications. Surgery may be considered in more complicated patients. We will now discuss pharyngitis. Pharyngitis is an acute infection of the oropharynx or nasopharynx. It results in 1% to 2% of all outpatient visits. While viral causes are most common, group A beta hemolytic streptococcus, or Streptococcus pyogenes, is the primary bacterial cause and is the focus of this section. In the pediatric population, Group A Streptococcus, or strep throat, causes 15% to 30% of cases of pharyngitis. In adults, it is the cause of 5% to 15% of all symptomatic episodes of pharyngitis. We will now discuss the microbiology of pharyngitis. Viruses cause most of the cases of acute pharyngitis. Specific etiologic agents include rhinovirus, that is 20%, coronavirus, that is equal to or more than 5%, adenovirus, that is 5%, influenza virus, that is 2%, parainfluenza virus, that is 2%, and Epstein-Barr virus, that is greater than 1%. A bacterial etiology for acute pharyngitis is far less likely. Out of all the bacterial causes, Group A, Streptococcus is the most common, that is 15% to 30% of persons of all ages with pharyngitis, and it is the only commonly occurring form of acute pharyngitis for which antimicrobial therapy is indicated. Other less common causes of acute pharyngitis include Groups C and G Streptococcus, Corynebacterium diphtheriae, Neisseria gonorrhoeae, Mycoplasma pneumoniae, Arcanobacterium hemolyticum, Yersinia enterocolytica, and Chlamydia pneumoniae. Treatment options for these organisms will not be addressed in this chapter. Next we will discuss the pathophysiology of pharyngitis. The mechanism by which Group A, Streptococcus causes pharyngitis is not well defined. Asymptomatic pharyngeal carriers of the organism may have an alteration in host immunity, e.g., a breach in the pharyngeal mucosa, and the bacteria of the oropharynx, allowing colonization to become infection. Pathogenic factors associated with the organism itself also may play a role. These include the antiphagocytic M protein, erythrogenic toxins, chemolysins, streptokinase, and proteinase. Group A streptococcal pharyngitis is difficult to differentiate from viral pharyngitis based on history and clinical findings. However, although all age groups are susceptible, epidemiologic data show that certain groups are at higher risk for Group A streptococcal pharyngitis. Children aged 5 to 15 years old are most susceptible, and parents of school-age children and those who work with children are also at increased risk. Pharyngitis in a child younger than 3 years of age is rarely due to Group A streptococcus. Seasonal outbreaks occur, and the occurrence of Group A streptococcal pharyngitis is highest in winter and early spring. The incubation period is 2 to 5 days, and the illness often occurs in clusters. Spread occurs via direct contact with droplets of saliva or nasal secretions, and transmission is thus worse in institutions, schools, families, and areas of crowding. See Table 107-7 for clinical presentation and diagnosis of pharyngitis. Non-suppurative complications such as acute rheumatic fever, acute glomerulonephritis, and reactive arthritis may occur, as well as suppurative complications, such as peritonsillar abscess, retropharyngeal abscess, cervical lymphadenitis, mastoiditis, otitis media, sinusitis, and necrotizing fasciitis. Acute rheumatic fever is seen rarely in developed countries. Acute rheumatic fever secondary to Group A streptococcal infection was a cause of concern in the 1950s and was the major reason for penicillin therapy, but the incidence of this disease today is extremely rare, that is greater than 1 in 1 million. However, the risk remains. Outbreaks have been reported in the United States as recently as the late 1980s and early 1990s. Furthermore, acute rheumatic fever is widespread in developing countries, e.g., it is estimated that there are 50,000 cases of acute rheumatic fever per year in India. Pause the video and carefully scrutinize Table 107-7 summarizing the clinical presentation and diagnosis of Group A streptococcal pharyngitis before advancing to the next slide. We will now discuss the diagnosis of pharyngitis. For a patient presenting with pharyngitis, the most important clinical decision that needs to be made is whether the pharyngitis is caused by Group A streptococcus. Diagnosis is essential because it directs management. Clinical scoring systems such as the Center criteria have been advocated for diagnosis in adults to overcome the lack of sensitivity and specificity of clinician judgment and to avoid laboratory testing of all patients. These criteria include history of fever, tonsillar exudates, absence of cough, and presence of enlarged lymph nodes. However, there is concern that use of these criteria will lead to overprescribing because they give physicians the option of a no-test strategy, where prescriptions can be written based purely on the clinical criteria. Guidelines from the Infectious Disease Society of America, the American Academy of Pediatrics, and the American Heart Association suggest that testing be done in all patients with signs and symptoms. Only those with a positive test for Group A streptococcus require antibiotic treatment. A combined approach would take into account the prevalence of Group A streptococcal disease, which differs by age group and geography, and history of a close contact of a well-documented case, along with clinical criteria, to aid in assessing a patient's risk of the disease. If the diagnosis cannot be excluded at this point, laboratory testing is recommended to confirm or exclude Group A streptococcus as the cause of pharyngitis. It is important to note that laboratory testing should not be used without consideration of clinical criteria. This is so because a positive test does not necessarily indicate disease. A positive test may indicate carriage, but not active infection, with group A streptococcus. The incidence of carriage in children is 5% to 20% and is considerably lower in adults. There are several options to test for group A streptococcal pharyngitis. A throat swab can be sent for culture or used for rapid antigen detection testing, abbreviated as RADT. Rapid antigen detection testing is more practical in that it gives results quickly, it can be done at the bedside, and it is less expensive than culture. Cultures are the gold standard, and have a 90% sensitivity but require 24 to 48 hours for results. Cultures are recommended for children, adolescents, parents, and schoolteachers with negative rapid antigen detection testing tests, which have a sensitivity below 80%, as well as in situations of outbreak or to monitor resistance. Delaying therapy while awaiting test results does not affect the risk of complications, although some argue that symptomatic benefit is postponed, and patients must be educated as to the value of waiting. Newer rapid antigen detection testing tests use optical immunoassay and chemiluminescent DNA probes, but the cost of such tests may be prohibitive, and results of individual tests should be compared with cultures to validate their sensitivity in practice. Next we will discuss the treatment of pharyngitis. Let's begin with the desired outcome. The goals of treatment of pharyngitis are to improve clinical signs and symptoms, minimize adverse drug reactions, prevent transmission to close contacts, and prevent acute rheumatic fever and suppurative complications, such as peritonsillar abscess, cervical lymphadenitis, and mastoiditis. We will now discuss a general approach to treatment of pharyngitis. Antimicrobial therapy should be limited to those who have clinical and epidemiologic features of group A streptococcal pharyngitis with a positive laboratory test. We will now talk about non-pharmacologic therapy of pharyngitis. Since pain is often the primary reason for visiting a physician, emphasis on analgesics such as acetaminophen and nonsteroidal anti-inflammatory drugs to aid in pain relief is strongly recommended. However, acetaminophen is a better option because there is some concern that nonsteroidal anti-inflammatory drugs may increase the risk for necrotizing fasciitis, toxic shock syndrome. Toxic shock syndrome has been linked to GAS pharyngitis. Either systemic or topical analgesics can be used, as well as antipyretics and other supportive care, including rest, fluids, lozenges, and saltwater gargles. Symptoms may resolve 1 to 2 days sooner with such interventions. Next we will discuss pharmacologic therapy of pharyngitis. Let's begin with antimicrobial therapy. Antimicrobial therapy decreases the duration of signs and symptoms by 1 to 2 days. Therapy also decreases the severity of symptoms when initiated within 2 to 3 days of onset in patients with proven group A streptococcus. Microbiological eradication will occur in 48 to 72 hours, which aids in decreasing transmission. Antimicrobial treatment should be limited to those who have clinical and epidemiologic features of group A streptococcal pharyngitis with a positive laboratory test. Penicillin is the drug of choice in the treatment of group A streptococcal pharyngitis, as shown in Table 107-8. It has the narrowest spectrum of activity, and it is effective, safe, and inexpensive. The only controlled studies that have demonstrated that antimicrobial therapy prevents rheumatic fever were done with procaine penicillin, which was later replaced with benzathine penicillin. The evidence that treatment of group A streptococcal pharyngitis prevents rheumatic fever comes solely from studies using depot intramuscular penicillin. Penicillin given by other routes has been assumed to be equally efficacious. The ability of other antibiotics to eradicate group A streptococcus has led to extrapolation that these agents also will prevent rheumatic fever. Amoxicillin can be used in children because the suspension has a better taste than that of penicillin. Gastrointestinal side effects and rash, however, are more common. In patients allergic to penicillin, a macrolide such as erythromycin or a first-generation cephalosporin such as cephalexin, if the reaction is non-IgE-mediated hypersensitivity with hives or anaphylaxis, can be used. Newer macrolides such as azithromycin and clarithromycin are equally effective as erythromycin and cause fewer gastrointestinal adverse effects. Second-generation cephalosporins, such as cefuroxime and cefprozil, or third-generation cephalosporins, such as cepodoxime and cefdinia, which are beta-lactamase stable, have been advocated for clinical failures with penicillin. In cases of documented macrolide resistance, owing to low-level macrolide resistance, erythromycin MIC 1 to 8 micrograms per milliliter, caused by expression of the M-E-F-A-E gene leading to efflux of macrolide out of the bacterial cell, clindamycin is an alternative. The new ketolides such as telithromycin also may have a role to play, especially in regions with a high prevalence of macrolide-resistant strains. If patients are unable to take oral medications, intramuscular benzathine penicillin can be given, although it is painful and is no longer available in Canada. Amoxicillin clavulanate or clindamycin may be considered for recurrent episodes to maximize bacterial eradication in potential carriers and to counter copathogens that produce beta-lactamases. Tables 107.8 and 107.9 outline dosing for acute and recurrent episodes of pharyngitis. To date, no resistance of group A streptococcus to penicillin has been reported in clinical isolates. Macrolide resistance is low, that is less than 5%, and is not widespread. However, there have been reports of an outbreak of macrolide-resistant group A streptococcal pharyngitis in the United States. The concern is that if macrolide use continues to increase, macrolide resistance rates also will increase. Therefore, use of newer macrolides as first-line therapy is discouraged in febrile patients with upper respiratory tract infections. Group A streptococcus resistance rates to tetracyclines and sulfonamides are high, therefore, use of these agents is no longer recommended. Overprescribing is a large concern that requires consideration. Antibiotics are prescribed in 73% of patients who visit their physician with a complaint of sore throat. This is well above the incidence of group A streptococcus. For those who receive antibiotics, 68% of prescriptions are described as being non-recommended treatments, e.g., extended-spectrum macrolides, e.g., azithromycin and clarithromycin, or fluoroquinolones, e.g., ciprofloxacin, gatafloxacin, levofloxacin, and moxifloxacin. Cost and resistance are factors that should discourage this practice. Pause the video and carefully scrutinize Table 107.8 summarizing dosing guidelines for pharyngitis before advancing to the next slide. Pause the video and carefully scrutinize Table 107.9 summarizing antibiotics and dosing for recurrent episodes of pharyngitis before advancing to the next slide. Next we will discuss a clinical controversy. The duration of therapy for group A streptococcal pharyngitis is 10 days to maximize bacterial eradication. Short-course therapy has been advocated to help overcome compliance issues that lead to bacteriologic failure. A 6-day course of amoxicillin shows promising results, as well as other recent studies with newer broad-spectrum agents, e.g., azithromycin, cefuroxime, cefprozil, cefdinia, cefoxime, cefpodoxime, and telithromycin, that have demonstrated durations of 5 days to be effective. However, confounding factors from these studies, such as lack of strict entry criteria or differentiation between new or failed infections, limit the widespread application of short antibiotic courses at this time. Furthermore, newer agents are more expensive and may be more likely to lead to resistance in light of the broad spectra of activity. Once-daily amoxicillin given at a dose of 750 mg is as effective as penicillin 250 mg 3 times daily, used for a duration 10 days each, in children aged 4 to 18 years with group A streptococcal pharyngitis. This dosing regimen has not yet been endorsed by expert panels but may gain support in the future if the results are reproducible. Lastly, we will discuss the evaluation of therapeutic outcomes. We will pay attention to contact cases. Most cases of pharyngitis are self-limited, however, antimicrobial therapy will hasten resolution when given early to proven cases of group A streptococcus. Fever generally resolves by 3 to 5 days and most other acute symptoms by 1 week. Tonsils and lymph nodes may take a few weeks to return to baseline. Children should be kept home from daycare or school until afebrile and for the first 24 hours after antimicrobial treatment is initiated, after which time transmission is unlikely. Follow-up testing generally is not necessary for index cases or in asymptomatic contacts of the index patient. Symptomatic contacts may be treated without cultures. In epidemics or in cases of severe infection, follow-up testing may be prudent. The incidence of invasive group A streptococcal infection in household contacts is rare, and routine chemoprophylaxis is not recommended by the CDC, although testing is advocated and guides management. 25% of household contacts are carriers, but treatment would only be required in persons with signs and symptoms of disease or contacts of severe or resistant disease. Thank you.